Good morning, everyone, and welcome. My name is Grant MacDonald, and I'm the Chief Operating Officer on the Trust. And I guess I'm just broadly comparing this session, so to speak. But in terms of, you would have seen the text around etiquette, but hopefully everyone's aware of staying on mute, staying in speaker view, and using your hand once we get to the question answer section, if that's possible. So what we're going to do, we're going to have a brief look at the national and local picture really around COVID-19. Clearly things change a lot at the moment, have changed a lot over the last month in particular, and changed a lot over the weekend. We'll have a wee bit of a look as well about where we are in terms of our staff and patients and how both the prevalence within the Trust but how we're managing. We'll talk, most importantly I think, really, how do we continue, whether as a leader or as a practitioner in the Trust or both, how do we ensure that we keep oneself safe, one's family and one's patients and their carers safe? And so that's really the primary task of this meeting, is how do we ensure that we get back to using all the measures we used in the first wave and learn from that and any developments of those into this period that's more challenging going into the winter. Really, then we'll, as I say, we'll have 10 or 15 minutes for questions and answers. We'll do our best to clarify things. If we can't, we'll take them away and we'll communicate them out. And we'll talk a bit about Paul will talk a bit about staff wellbeing and testing. And then we will close. And this has been recorded so colleagues can be shared with colleagues if you feel it's useful. To start with, I think I'm handing over to Carl, who's going to just give us a brief update in the national and local position.
Good morning, good afternoon actually, everyone. Just to give you an idea around the context of where we are in Southern Health. You've obviously been watching and being updated in the weekend, the changing nature of COVID and how it's affecting us. So the cases are obviously well known to be very high in the northwest and northeast, with the numbers of the R number, which is doubling rates, to that number above 1. So we know that the rates in the community are above 1, and we know the rates in our hospital settings are also above 1. So as you see there, it means an average of 10 people will affect 11 and up to 13. But just to note, this is not just about doubling, this is about a logarithmic increase. It increases, then it goes up like that. So it's a really steep rise that we're going through at the moment within the country. So if you think that about us in the southeast, we're the second lowest rate nationally in the country after east of England, which is Norfolk and Suffolk. So we are in the southeast, have a wide crescent from Sussex and Kent right the way through to Hampshire and up to Oxford. So we're in the southeast, one of the lowest rates. As you see at the bottom there, the numbers of infections growing 2 to 4% every day. So in the southeast, we are expecting the numbers of rates of COVID infections to double every 12 days. So that is currently in the southeast, the highest rates are in young people, those up to the age of 30. But we also note that the numbers in the southeast and nationally above the age 65 are increasing at that same rate. A couple of weeks in delay behind for those numbers, particularly about the 65 and above, are increasing. So in Hampshire, we are part of the southeast. You can see the alert level. Obviously, that's changed with the national lockdowns coming into effect, potentially going through Parliament on Wednesday and coming into effect on Thursday. There's a little bit of an update from the slide today. So right across the region, there's an increase in rates. You see there that currently today, in the southeast, we have something like 665 patients in hospital, and currently we have 50 people in ITU. This is quite a low rate from where we are in April or March. But those people in ITU are in ITU with COVID, but there's around the rest of the ITU beds are utilised by non-COVID patients. So even in the southeast, when we know that our numbers of people in ITU are approximately 50 people at the moment, we know that the occupancy of ITU is significantly above where it was in April and March. So they are currently 2 times the number of people in hospital ITU beds which are non-COVID. So the COVID patients are small, but actually the number of non-COVID patients in ITU are significantly higher than they were in April and March. I'll go on to the next slide. So a little bit of an update to these figures. I've just updated it from this. So you have updated it this morning. So we have 14 COVID positive patients today. And we know that the majority of those people are in our physical health beds, but there's a significant number in our older people's mental health beds. The vast majority, 90% of these individuals who are COVID positive are above the age 75 and above. So there are there are people who are under the age of 50 with COVID positive at the moment in Southern Health. We have, just as update, we have noted on the slide is 30 staff are self-isolating. The update this morning at 8 o'clock is that we have 40 people isolating. And you will know in your various divisions that there are people isolating. And those are particularly out of those 14 or 30 self-isolating at the moment. 16 of those people are specialised, 7 in Southampton, 6 in Southeast and Southwest, and 4 in North and Mid. So that's out of 6,360 staff. So the numbers are small when you look at the massive number of staff that Southern Health employs compared to the numbers there. The numbers of people of sick, as you can see there, those are specialised and Southeast in particular. And when people are sick, these are people who are not working. There are people who are self-isolating and who are potentially COVID positive, who are continuing to work and are self-isolating and working. And those are relatively small numbers in their 20s. So you see at the bottom of the slide the things we need to consider. If any of you are interested, you'll be noted that the Health Care and Safety Investigation Board has published something last week, and it's talking about how infections occur within a healthcare setting. And it's important to note the major thing that we need to be doing is thinking about how we can have increased capacity in our beds, because that's the greatest risk of people coming together, both staff coming together in small areas, and also patients and patients in small areas. So one of the biggest issues in bed capacity, just thinking about the least restrictive thing to do, which is actually caring for people in their own homes. So we need to have a concentrated effort on thinking about those individuals who are medically optimized, who can go home and actually have care surrounding them at home or in the community. So this is going to be a significant area for us to consider about medical optimization of patients who can then go back and be treated in the community, either by our own services or by primary care. Single sex, as you know, is a CQC area of inspection, and they're looking at single gender environments, and some of our older people's wards have that capacity to have a bit of a swing in how much male and female beds they have. But this is something that we need to be concentrating on, and actually we're going to keep our CQC colleagues up to date with any changes that we have. The bigger issue, which Paul will come on to, is around us making sure that we are COVID secure in our environment, but also we're using personal protective equipment in the right way to protect our staff from the virus, and also to make sure that we're not spreading it so that our staff have to be isolating and putting our patient care at risk because we're not able to come to work, especially in inpatient settings. Since the announcement on the weekend, this Thursday we'll be looking again around how safe we can have our environment, and those are considerations around our visitor sites and how we can enable visiting while at the same time making sure that infection procedures and controls are in place, and IPC controls are in place, and leave for patients as much as possible, moving patients to a home environment where they can be supported by our own staff and by primary care, and most importantly by also supporting carers, family and friends in supporting those patients who are going back in the community. Those are some areas for consideration. I'm sure you'll have some questions and some discussions later on in this session. Hand over now to Sarah and Jackie.
Thanks. Morning, everybody. Jackie and I just thought it might be timely for us just to draw your attention to some of the really kind of basic infection control practice that we need to work together to raise people's awareness again. So you will remember back in March and April, we were very focused on this. And what's happened is over the summer, as things have kind of normalized, we've relaxed a little bit. So this slide is really important, just reminder for you about getting back to basics and how important these strategies are. Now, the consideration that we need to really carefully think about is people are really tired. So human factors are beginning to play in and affect our ability to make decisions, which is completely normal. So as leaders and working as team members, we need to think about how we are, how we're feeling and how our colleagues are feeling so that we can support them in the right way. These are not criticisms, that it is a natural human factor impact that people are worn out. So we need to support them and help them to get this right in the right way, in a compassionate way. So we've had 6 panels over the last week where we've had either a positive patient case, confirmed case, or a positive staff member confirmed case. And to make sure that we're maximising the learning from those 6 panels, in all of those cases, we had relaxed. You know, we had made a decision that put ourselves at risk with an asymptomatic person that we didn't realise. We'd just taken our eye off the ball. So the really basic things that we want you to remind every person to do, including ourselves, to just go back over it. Are we definitely doing this? Is to remember in all of our clinical settings, and it doesn't matter what specialty you are, it's really important to remain bare below the elbow. We know that COVID will transmit from surfaces and highly likely through your hands. So just remind people all of the time around the importance of being naked below the elbow. This helps them wash their hands, and that includes their wrists and forearms. We know that it can live on the surfaces. So that's the first thing. Secondly is around wearing the correct PPE. So in every case in the panels over the last week, there's been some softening of our understanding of what that correct PPE looks like. So 2 main things that I want to remind you of. You can obviously check the whole guidance and these links will take you to that, but the 2 really big pieces of learning, firstly, were around wearing your mask. So we sent some messaging out last week. It's really important that you're wearing your mask, so a surgical face mask, not the face covering that you wear in the supermarket, a surgical face mask everywhere. And that is in addition to social distancing. The only exception to that would be if you're in an office on your own. Of course, you don't need to sit in an office on your own with a mask on, but you would need to wear a mask possibly to walk through a corridor to get to your office. And then you need to remove it and throw it away in the bin. So don't put it on your desk and then put it back on again, because the outside of the mask will potentially become contaminated, either from the environment or from somebody that's asymptomatic that you didn't realise. So you must wear a mask everywhere in addition to social distancing, unless you're on your own or you're eating and drinking. And of course, just remember when you're eating and drinking to remain socially distanced. And the second one is around eye protection. And this has come up on a couple of our panel discussions where people either were not clear on when to wear eye protection or had forgotten to include it. So for anybody that you're providing direct care for, so obviously not in an office with your colleagues, but if you're having to work closely with the patient, which many times when we're delivering direct care, we may have to do that. If we do not know the testing status of that patient, so they are, say, for example, a new admission, who you've not got a test result on, it's really important that you protect yourself by wearing eye protection as well as your mask. So that could be the visor, or it could be a set of goggles. The virus can be contracted through the tissues in your eye. So if somebody is symptomatically coughing and you're within 1 meter of them, it can be transmitted through your eye and through your mucosal surfaces in your mouth. So it's really important to make sure that if you do not know the status of, say, a new admission, that you've got eye protection, and if you have a known positive case, that you are wearing eye protection to deliver that close contact care. Washing your hands, obviously, you know, we talk about that every day, really basic, getting back to basics, thinking about that everywhere you go, every time you touch things. Can you just increase the frequency in which you're washing your hands? You do need to look after your skin if you're using alcohol gel, because it will dry your hands out. But and definitely washing your hands before and after putting on or removing PPE. Talked about face masks. It's come up a couple of questions in the last week around washing clothes. So we're not describing this as uniform, because this actually applies to your own workwear. Some people don't wear uniform. But if it's possible to get changed out of your workwear before you travel home, we would obviously encourage you to do that. Now, I absolutely appreciate that's not always possible. If you can do that, bring a change of clothes, bag up the clothes that you've been wearing, your workwear, and then just wash it as soon as you get home at 60 degrees. And that will kill the virus if there will happen to be any on your clothing. So, but that does apply to our normal dress, not just our uniform. If you're not able, you don't have a changing facility where you work, it is okay. You can drive home, but you just need to be conscious that there could be virus on your clothing, which obviously is in your car. In your car outside overnight for a period of 24 hours, any virus that's in there would have died. It can't survive at a low temperature outside of normal temperatures. So you would be okay, but you just remember, if it's possible for you to change, then please do change your clothes and take it home bagged. And then you can just put it in the washing machine when you get home. Remembering to clean your surfaces as part of your COVID secure environment. All those touch points, telephones where multiple people pick up the phone is really important. So as well as your hand hygiene, cleaning those touch points much more frequently than we would do normally. All of your environments have been risk assessed with our cleaners. And we do quite a lot of close work with MediRest on that if we needed to increase or decrease that at any point. But things like your own computer, keyboards and things like that, we have to take a personal responsibility to make sure we've cleaned those if we've used them. Really importantly, if you develop any symptoms at all, you must self-isolate and organise to get a test. And the only other time we may want you to get tested is if, as part of an infection control team review of your ward or a positive case, you may be advised, and we would sort that out for you to be tested. Practice strict social distancing. This is an important one. This is a direct learning from our 6 previous panels in the last week. Again, in many of those cases, we've just relaxed a little bit. So we've had a one-to-one meeting with another member of staff in an office, and we've sat within 1 meter of each other without masks. And then later on, the member of staff has been identified as being an asymptomatic positive case. So again, it's completely natural. People are tired and have stopped maybe thinking quite as robustly. Don't have one-to-ones face-to-face if you don't have to. If you do have to do that, book yourself a much bigger space, or you could always meet outside. But as the cases in the community increase, we will have more asymptomatic people, and we're not currently in a position to be able to test every NHS worker. So just really, really use virtual platforms as much as you possibly can. And that includes for meetings, so handovers. Really think about where you're holding those meetings and can you truly social distance. And if you can't, you need to wear masks or look at a virtual platform. Wouldn't be okay if I talked to you about infection control and didn't mention flu. We obviously are going into flu season, so please encourage all of your teams to take up the offer of a flu jab. This year it's going to be even more important than it ever has before. Both viruses are circulating at exactly the same time through our communities. You can protect yourself against flu, so please encourage your staff to do that. And we will include on this slide deck the IPC checklist, and it does go through all of these things for you. You can pull it out, print it off, and just ask yourself in your own practice, in your own teams, have we got this really robustly in place? Jackie, is there anything else you would like to add?
I think you've covered everything. I did wonder if it's worth mentioning, now it's getting colder, that as staff go into people's homes, you mentioned about bare below the elbows, and we also talk about workwear, but people are going to want to keep warm, and so think about what you're taking into somebody's home. If you take a coat in, that coat isn't easily laundered, so maybe now's the time to get something that's easily washed, like a fleece or a cardigan that can be washed at a high temperature. And I can see in the chat you're right, we don't all wear workwear that can easily be washed at 60 degrees, but I think that's what we're aiming for, to try and wear things that are not delicate that you can throw in a hot wash. And be careful what you take in. And also you mentioned about face-to-face meetings being reduced as much as possible, but also really thinking whether we have to be in the office, whether we can work from home. And there's lots of benefits I know from being in the office, but as the virus level increases, there's also quite a lot of risks the more we bring people into the environment.
Thanks, Jackie and Sarah. If it's okay, I'm going to jump in there and try and get to some of the questions. I appreciate time's galloping on, but that was probably answered a lot of the questions as you went. So I've picked up most of the questions in the sidebar, folks. If you've got any more, please do put them in or raise your hand. We obviously are very tight for time, but I just want to rattle through some of the questions, and I will give a perspective instead of going to my colleagues the way I would usually and ask, but I'll go if I need to. But if not, I'd like people to contradict me if I've got it wrong, because I'm happy to be wrong and us get to the right answer together. So the first question that we got was around PM's message around over 60s, taking more care, and would we be doing anything? I would have thought not. I think that in terms of people at that age should have had an individualised risk assessment already, and that should cover it. I hope that's correct.
Yeah, no, absolutely, Grant. And we've got the latest edition of the risk assessment out this week with the training materials too. So I think it's just worth rechecking those and making sure that they are robust as possible. So, but absolutely right. People should have risk assessments, and we need to follow those.
And that, by the same token, should that take account of staff who were asked to shield in the first wave? Yes. Okay, I'll take that as a yes.
Yes, sorry, I lost my cursor. Yes, absolutely.
Okay, yeah. So there was a question around updates from will you get local updates? Yes. The command structure, which I'm sorry for those words because it's not what we want to do. We want the communication structure is probably better. From bronze, silver, gold, to use that language, will continue and should continue alongside the updates and the communications from the centre that will probably increase the frequency of. But I don't think there's anything better than receiving that message through your direct line and face-to-face. So we'll ensure that happens. There's a question around University Hospital Southampton have changed their guidance around pregnant staff from 28 weeks. I presume they've reduced it. It doesn't say in the sidebar. As far as I know, we don't have any plans to do anything with that at this stage, but I think Paul indicated... I think the national guidance has changed, and so I think we're following the national guidance. So I think UHS have as well. Which is what they're probably running in front of, but we'll do it in line with that, Sarah clarified about eye protection. I think there were some questions about that. I think people have answered the questions around clothes, although I do think the uniform, I think Jackie's point was really important. around trying to, for the winter particularly, something that's warm that can be laundered appropriately, and we need to consider where we, if we need to provide that, we provide it. I think Jules put a point in that Paula answered around scrubs, and yes, people should have access to scrubs in ordering those, or uniform, or whatever's required, so to speak. I think Paula answered that. There's a question about, Paula, could I come to you just briefly in this one around increasing observations in the community? I would have thought potentially not really, but I'd just be interested in your perspective. Somebody was asking, because of the increased incidence, should be increasing obs in the community, for example, pulse oximetry with community patients?
Yes, and there is, certainly for long COVID, there is some guidance that's coming out around increasing oximetry and particularly doing regular SATs monitoring in the community for people with long COVID. There isn't any particular monitoring other than is normally in place, so I would expect a normal community practitioner to have a SATs monitor as part of her equipment. And obviously we need to be vigilant when we're going out and visiting people, and if we feel there's a deterioration, we feel that we need to take a set of observations to ensure that they're not deteriorating in their clinical health, then we would do the same as we normally would do, I think, in those situations. We have also had some guidance about shielded patients, so we're just working through that at the moment. People who may have been shielded or been seen as being extremely vulnerable on our caseloads, and even those that might have been discharged in the last few months. And we're just looking at those now, and we're hoping to get some reports coming out to you to be really clear who those people are, so that you can make sure that you are providing the right observation and oversight of those vulnerable people.
Brilliant, thank you. And I think just a minute, I appreciate we're over, but I just want to try and finish the questions in 2 or 3 minutes, if that's okay with people. If you can't stay, don't. Issue about staff returning. People have returned to bases that maybe don't need to be there for a range of reasons. If they're for personal reasons and they are because of work environment, people need to negotiate that with their managers. But no matter what the national lockdown says, we want as many people to work from home who can. But the can might be for a range of reasons to do with the mode of delivery of the care they provide, but it also might be to do with the home circumstance. So the message with that, I don't think, is changing. If people are just coming in for a chat and they're not linked to their mental well-being, I should add, then they shouldn't be in. But I doubt there's many people doing that, but I think that's important. There was a question around disposal of masks in non-clinical areas. I think Jackie or someone can clarify that, but I thought it was yellow bags, but I hear it's orange bags we're meant to be disposing them in. But in non-clinical areas, how should we dispose of bags, Jackie?
If you come to your office and you need to take your mask off because you need to change it, perhaps it's damp or you're now the only one in the office, it can go in the black bag in the office setting. We are assuming that people who have worked in a ward setting actually take their clinical mask off. If they've cared for somebody in isolation, you'd have to change your mask then. So in a ward with isolation, it would be orange bag, but actually in an office, it's black bag. And
Jen was saying the community that don't have yellow bags.
No, so there the waste is going into a bag and it's being held for 72 hours and then it's being put into the large sort of normal domestic house waste from the household with the permission of the householder.
That's helpful. And then there was a range of questions around, will we be asking to relocate people like we did in the first wave? Certainly, leaders and managers in the trust are looking at what redeployment and contingency plans there are for staffing. I don't think it'll be the same scale, because certainly the biggest redeployment was from children's services, not to 19 services, and that won't be happening because we know the impact that this has had in families in the first wave and children in particular. So that mass redeployment wouldn't happen from there. But in terms of redeploying staff from non-clinical roles back into clinical roles and stuff, that's something we actually have been looking at and will continue to where required. And I think a point about the disposal of masks, maybe we need to clarify that in some comms as we go, but it should be a black bag with a lid. I would have thought, yes, if possible, and I know that a lot of black bins might not have. So I think that probably needs some consideration. I've jumped through a lot of questions there for the sake of time. I think where it points us to is we probably do need more time in this, and we will take opportunities. It's just a start of increasing our comms around this. So and there's one final question, not a final question, but a question just jumped in around increasing infection rate in the community. Do community mental health teams reduce face-to-face contacts? I think the answer is still exactly the same. People should continue with face-to-face contacts where it's in the need of the patient or potentially at their choice request, and people should be balancing the risk. I'm sorry, there's not a simple answer, but I think the relative risk between COVID or somebody having an appropriate contact based on their need is what we need to balance. So we should probably continue as we were broadly. I'm reluctant to say any more questions because I can't see any more in the sidebar, but if there is anything that feels burning, and I'm sure there are things, I guess it's a matter of finding out through your own line. You can contact your infection control team. Infection control staff have been great. We do need to briefly turn to the most important bit in some ways. I think I said that the section that Sarah and Jackie done was most important, which it is, but alongside that are in parallel staff wellbeing. And I'm sorry, Paul, we've sort of come short of time, but I still think we should take a minute or two in that.
No, thanks, Grant. And I think you're right. I mean, it's I think the way you opened the bit about ensuring that we keep our families, ourselves and our communities safe, I think is absolutely critical. And that includes our own well-being as well. I'm really delighted that over half of our organisation has taken advantage of the wellbeing offer that's digital. And I think that will be up on the slide. But there's lots of feedback that we're having, and we need to continue the feedback on gaps. So just briefly going through a quick couple of updates. Digital wellbeing has come up as an issue, and we've got a number of things that are coming around on digital wellbeing as more people work from home and spend a lot of the time doing this. So there are some seminars coming up, and there is also a guide come out as well on that. Wellbeing assessment I've touched upon. Health and lifestyle checks is something that we've done particularly for high risk staff, and they'll be extended in the new year to everybody, and they'll include broader support for BP, BMI, looking at blood sugar levels and so on to help to just ensure that we're okay and help them refer into to your own GP to support. Wellbeing champions are now in place. We've also got carers wellbeing package. So for those who've got caring responsibilities on top of work, we know that the demands are challenging at the best of times, and as we come into the new lockdown, please visit the site. There's lots of social media out there, but please go and have a look at what we've got. There's a lot of support now that we can offer. Wellbeing seminars I've touched on, and the listening ear, just a reminder that we've got quite a lot of really good psychological support on tap, and things like listening ear as well as IAPT and CISM for debriefing. But the listening ear now is open 7 days a week, 12 hours a day, and that's running, and we're well into three figures now in terms of contacts through listening ear. And again, linking back to what Grant said earlier, and I think the points, and I think Carl touched on as well, our biggest reason for people contacting is loneliness and isolation, and I think we have to just bear that in mind as we support each other again as we go through this. So yeah, the biggest contact for listening now is loneliness and isolation from our colleagues, and these are all our colleagues. So again, if we can support each other and just maintain that that connection and look out for each other as we go through into the next phase, and generally, but particularly as we go into this next phase, that would be really important. And just a thank you to everyone. It's been incredibly hard and challenging, but everybody's risen to the challenge and continues to. So just look out for each other. Thanks, Grant.
Thank you, Paul, and thank you, everyone. I mean, we do need to draw to a close. You can, as it says in that slide, get information from the internet. If that's not good enough, talk to people. If that's not good enough, email people like me, Paula, whoever you please escalate stuff. We need to work together to get this right. A couple of questions just to finish on. No specific advice for over 60s beyond if they're worried, revisit the risk assessment that was individualised to them, but that will come a bit more out in the wellbeing stuff. There's no specific plans. We will look at visiting and check it's at the right level. It's currently restricted. And we do need to think about children who are carers in that context and the impact on young people and children particularly. But as Paul said, everyone, really sorry. I would like to keep going, and we will, because I think it's only clarifying thinking about this. And I think the way that Sarah and Jackie put some of the stuff around how we manage this is really what we need to focus on. But these slides are available for people, as are the links. I think we need to, comms will think about how we replicate this in a recurring way, because I think it's only 100 people have gone here at 6,000, but I'm sure you'll spread some of the message. Keep asking questions, take care of each other, wear a blinking mask all the time and wash your hands. Thank you for your time. All the best.
Thanks, everyone.